Respected seniors, colleagues, and dear postgraduates, good afternoon and a warm welcome to you all. On behalf of IADVL AP, we are conducting these PG clinics. With overwhelming response throughout AP and across states, we are even trying to conduct these with increased vigor. This is our 6th PG clinic in a consecutive PG clinic. We started this to improve clinical skills of postgraduates, and I hope this is helpful for the postgraduates throughout AP. Today, our case is a long case presentation of erythroderma, and our internal examiner for today is Professor Dr. D. Subbarao, Professor and HOD, Ashram Eluru. Sir, thanks for volunteering to take up this PG clinic for this month. And our external examiner for today is Dr. Malati Muniswamy, Additional Professor and HOD, JIPMER, Puducherry. And today our presenters are Dr. G. Prananka and Dr. N. Soumya. I would like to ask our President, Dr. Kavita, to say a few words.
Good afternoon all. Warm welcome to all of you for this PG clinics. I am extremely thankful to Dr. Subbarao sir for volunteering to take this PG clinics this time. And we extend our sincere gratitude Dr. Malati madam for kindly sparing her valuable time. And this is erythroderma is a long case for the PGs, but it is even challenging to all the practitioners also. It's one of the dermatological emergency where we all need to diagnose the condition, and I think it's useful both not only for the PGs, for the practitioners also. And wishing you all a happy learning. And over to Dr. Saujanya.
Thank you, madam.
And my thanks to Dr. Nirupama, our Joint Secretary, for taking up this program on behalf of Master Medical College.
Thank you, madam. Rohit, can you share the CV of Dr. Malati Muniswamy, our external examiner today?
Yes, ma'am. Yes, ma'am. Is my screen visible, ma'am?
Yes. Can you make it like full screen? Yeah, thank you. So, Dr. Malati Muniswamy, we are proud to have you here and very happy to have you here. She did both her undergraduation and post-graduation from JIPMER, and she's at presently additional professor, Department of Dermatology and STT in JIPMER. Previously, she's associate professor and senior resident, all in JIPMER only. She participated in 40 research projects and published 60 articles in national and international journals. She presented 30 papers in national and international conferences and authored 4 chapters in textbook and co-authored up to 16 chapters in various textbooks. She's a guide for 15 postgraduate dissertations and co-guide for 16 postgraduate dissertations. She received 4 extramural grants, 3 as principal investigator and 1 as co-investigator. She's a member of IADL Academy and coordinator of IADL Observerships. She's a member of SIG Pediatric Dermatology, and she's an external member of SAC of Sri Muthukumaran Medical College Hospital and Research Institute. She's the assistant editor in Pigment International Journal, and our areas of interest are chronic urticaria and skin allergy, pediatric dermatology, immunodermatology, leprosy, STI, and clinical research. Thank you, madam, for accepting us today. Rohit, can you share Dr. Subbarao sir? Thank you. Sir did his MBBS at Andhra Medical College in 1978 and master degree in Guntur Medical College. He was awarded the 10th IADVL Gold Medal President of IADVL AP of 2022-23. And he started practice at Eluru in 1981, and he's presently working as professor and HOD at Ashram. He attended 25 state, 15 national and 2 international conferences, co-chaired 18 sessions, and organized state conference of AP Cuticon successfully in 2016 as well as 2023. He presented various papers at 16 state meets, 2 South Zone, posters at 4 national and 1 international conference. He published 6 papers in various national journals, and gave more than 85 guest lectures on health awareness and AIDS for various gatherings at Eluru. He conducted 725 pre-skin camps and 63,000 patients were benefited. Thank you, sir. Now, I request Dr. Subbarao sir to take over the further proceedings.
Good afternoon, everybody. First of all, I thank IADVL AP State President and Secretary and Office Bearers for giving us this opportunity. I thank Dr. Malati Muniswamy Madam also for having accepted to be the external today. And today we are very much pleased to host this clinic. And two of our senior postgraduates will be presenting a case where there will be discussion about the various conditions. So I request you all to kindly participate and ask your others also to log in also. And with these few words, I thank you all once again for having joined again. And if Madam is ready, we'll start with the case, and our PGs will be presenting the case. Dr. Malati Madam, can we start the case, please?
Yes, sir. Good afternoon, all. I thank IADVL AP for giving me this opportunity and to share my knowledge with all of you. And this is a very good initiative, which I hope postgraduates will benefit from this discussion. Thank you, sir. Thank you all.
Thank you, Madam. Dr. Kavita, can we start, please?
Yes, sir. Postgraduates can share their screen.
And Dr. Prananka and Dr. Soumya can start the case presentation, please.
Sir. Good afternoon, everyone. So today's case presentation is a 39-year-old married male, teacher by profession, hailing from Bhimavaram, came to our OPD with chief complaint of red raised lesions over both the hands and legs, abdomen, chest, groin region, and scalp since 2 weeks, associated with itching and burning sensation, and chief complaint of fever since 5 days and swelling of the feet since 4 days. History of present illness: the patient started developing red raised lesions with copious scaling over the lower back and gradually progressed to involve both the upper limbs and lower limbs, chest, abdomen, scalp, and genitals, arms, and soles. It is also associated with itching and burning. Patient mentioned whitish scales all over the bed. There is history of intermittent fever with chills and history of aggravation of lesions in meters. There is a history of usage of unknown topical medication in the past. There's no history of joint pains, no history of malar rash, no history of photosensitivity or exposure to allergens, no history of fluid-filled lesions, no history of proximal muscle weakness and rash around the eyes, no history of discharge per urethra or diarrhea, no history of weight loss. There's no history of atopy, no history of sexual exposure, and no history of cough, shortness of breath, easy fatigability, no history of cramps of the hands and feet, no history of confusion, seizures, nausea, vomiting. The past history: it is a known case of psoriasis vulgaris since 20 years as diagnosed by a dermatologist. He was on tablet methotrexate 7.5 mg weekly for 1 year, along with tablet folic acid 5 mg, and tab cyclosporin 100 mg daily on and off. The patient, being a teacher, started his own research on psoriasis through Google and used some Ayurvedic medications in the past. History of sudden withdrawal of oral 30 mg 3 weeks back. History of depression since 10 years and was on antidepressant medication in the past. No history of diabetes, hypertension, TB, epilepsy, surgical illness. Personal history: the patient takes mixed diet and appetite is decreased, sleep is adequate, his bowel and bladder habits are normal, there are no addictions like smoking and alcohol. Family history: there are no similar complaints in the family. On general examination, the patient is conscious, coherent, and cooperative, well oriented to time, place, and person. Patient is moderately built, moderately nourished. Pallor, icterus, cyanosis, and clubbing is absent. Lymphadenopathy is present, with unilateral horizontal group of inguinal lymph nodes were palpable on the left side. Pedal edema, that is bilateral pitting type of edema, is present. His vitals: pulse is 88 beats per minute, His blood pressure is 110/80 mm of mercury. His respiratory rate is 14 breaths per minute. Temperature is 100 degree Fahrenheit. And weight is 76 kgs. His SpO2 is 98% with the room air. On cutaneous examination, there is diffuse erythema scaling all over the body, including the scalp and trunk, both the upper and lower limbs, and genitals. Scaling is extensive. There is adherent, large, silvery white scales, predominantly over the extensors, back, and gluteal region. There are few erythematous blocks with scaling over the palms and soles. There, on the scalp, there are multiple erythematous blocks with silvery scales extending beyond the frontal hairline. And the face is paired in this patient. Auspitz sign is negative. His eyes, oral cavity, and other mucosal areas are normal. Hair is normal. These are the clinical pictures of the patient. Nail changes, pitting, onycholysis, nail dystrophy, and subungual hyperkeratosis is seen. The lymph nodes involvement is seen. They are unilateral, firm, non-tender, discrete, horizontal group of inguinal lymph nodes were palpable. On systemic examination, CVS, S1 and S2 is heard, and there are no murmurs. Normal vesicular blood sounds are heard, and no focal neurological deficits are seen. On per abdomen examination, it is soft, non-tender, and there is no organomegaly. The investigations we have done are baseline investigations in which on complete blood picture, the total leukocyte count is 11,700 and the RBC is 3.7 million per cubic mm and HP is 10.5. Lymphocytes are 8.4%. Eosinophils is 10%, that is elevated, and ESR is 78. The C-reactive proteins are 12 mg per dl. LFTs are within the normal limits. RFTs are within the normal limits. Serum electrolyte, sodium is 129 milliequivalents per liter. Potassium is 4 milliequivalents per liter. Serum albumin is 3.2 gram per dl. The RBS is 108 mg per dl. Complete urine examination is normal. Chest X-ray is normal. And the viral markers are non-reactive. So we have done a biopsy. The histopathological report showed serial sections reveal the structure of the skin with epidermis lined by keratinized squamous, stratified squamous epithelium, showing hyperkeratosis, parakeratosis, and acanthosis, with bulbous elongation of the reader ridges. Stratum corneum shows focal Munro's microabscess, and papillary dermis showing many capillaries. The focal perivascular lymphocytic infiltrates were noted in the upper dermis, and there is no evidence of malignancy. All the features were suggestive of psoriasis. So the summary, it is a 39-year-old male patient who came with the chief complaint of generalized erythema with silvery white scaling over the abdomen, trunk, upper and lower limbs, genitals associated with the nail changes and scalp involvement. He is a known case of psoriasis for the past 20 years and now presented with acute exacerbation since 2 weeks. And there's a history of sudden withdrawal of oral steroids. So my provisional diagnosis is acute erythroderma secondary to psoriasis vulgaris. So treatment, we started with general measures. We hospitalized the patient. Vital monitoring was done, that is temperature, pulse, respiratory rate charting was done. And thermoregulation was maintained by warm, humidified environment is maintained. Plenty of oral fluids were given. Nutritional supplement with high protein diet was given. Specific management is injection dexamethasone 2 cc once daily in the morning for 1 week. And then gradually tapered. We have given injection phenidamin malate 2 cc at night, injection ceftriaxone 1 gram twice daily, and capsule polycalciferol 60,000 international units once a week, capsule omega-3 fatty acids once daily, and tablet ferrous ascorbate and folic acid once daily, tablet calcium 500 mg once daily, tablet paracetamol 650 mg, liquid paraffin all over the body twice daily, and beta-methasone dipropionate 0.05% and salicylic acid 3% lotion over the lesions of the scalp, and clobetasol 0.05% foam over the body lesions.
Okay, thank you very much for your presentation. And I request Malti Madam to kindly start with your questions and
Thank you, sir. Thank you for the good presentation. Now I would like to start off with, you presented your case as a case of acute erythroderma. So what in your examination told you that your patient is having erythroderma? It could be an extensive psoriasis. So why did you give a diagnosis of erythroderma?
So there was involvement of more than 80% of the body surface area with erythema and scaling. And also he had a history of sudden withdrawal of steroids, and the patient being a known case of psoriasis, when there is a sudden withdrawal of potent systemic steroids, we can think of erythroderma.
Yes. So we have to mention the body surface area involvement. So we call it as an erythroderma because the body surface area involvement was more than 90%. Ideally, the definition of erythroderma now is erythema, scaling, and infiltration, which is involving more than 90% of body surface area involvement, except for your erythrodermic mycosis fungoides, where we retain 80% of involvement as erythroderma. So more than 90% is considered as erythroderma. What do you mean by acute erythroderma? Why do you want to differentiate an acute versus a chronic erythroderma? What is the importance of differentiating it?
Acute erythroderma is if it is seen in less than 6 weeks, while chronic is more than 6 weeks. In acute erythroderma, the scales are usually large and adherent scales and associated with crusting. In chronic, they are dry and loose. Small scales are seen.
What is the relevance? Why do we need to differentiate whether it's a case of acute erythroderma or chronic erythroderma? Okay, acute skin failure, a complication of erythroderma, is more common in which type of erythroderma? In an acute erythroderma or a chronic erythroderma?
Acute erythroderma.
So that is why, because complications, acute complications of the systemic complications of erythroderma are more common when your patient develops a acute erythroderma. What do you mean by unstable psoriasis?
Lesions are progressing even on the systemic treatment.
So when do we call it as unstable psoriasis? Is when there is surrounding erythema around the lesion, which is a marker of progression. So that is what tells us whether this patient is going to progress into an erythroderma. For example, a patient who's having a chronic plaque psoriasis, and then you find there is angry looking erythema, which is surrounding the plaques. And especially in these cases where they've been taking steroids and there's a sudden withdrawal of steroids, this erythema is going to indicate that these patients are having unstable psoriasis and they might immediately land up into an acute erythroderma. So shall we go to your history? You had told many negative histories. Can you please tell the relevance of asking those histories? Why did you ask for those histories?
No history of joint pains. It is to rule out any psoriatic arthritis or Raynaud's disease. And history of malar rash to rule out cutaneous LE. And history of photosensitivity also to rule out any photodermatitis or cutaneous lupus erythematosus. And the history of exposure to allergens could lead to ABCD. History of fluid-filled lesions to rule out any immunobullous conditions, and history of proximal muscle weakness and rash around the eyes to rule out dermatomyositis, and the history of discharge per urethra or diarrhea to rule out Raynaud's disease. History of weight loss to rule out any chronic conditions or malignancies. History of atopy to rule out atopic dermatitis, and the history of sexual exposure to rule out any secondary syphilis or HIV treaters. History of cough and SOB to rule out complications of erythroderma like pneumonia or high output cardiac failure, etc. History of cramps of hands and feet is to rule out hypokalemia, which is the complication of electrolyte imbalance, which is the complication of erythroderma. And also history of confusion, seizures and nausea, vomiting to rule out hyponatremia, which is also a complication of erythroderma.
Very good. So when you're presenting a case of erythroderma, once you talk about the chief complaints and progress with the history of presenting complaints, how the disease evolved, we should also talk about other negative histories or positive history to look for the reason for erythroderma. So we know that erythroderma can be caused by a variety of dermatosis. So we need to identify the cause. In this case, we know that the patient was a known case of psoriasis and it's an acute exacerbation. But in cases where the patient first time presents to us in erythroderma, we should always find out the various causes. So we should ask for relevant positive and negative history, and that has to be presented. And the second part of the history should have positive or negative histories of the all possible complications of erythroderma. So that has been presented well. Good. Now going on to your examination. Can you just go on to your examination? Yeah. So you have to mention about the body surface area involvement. And is there any other disease activity index that you need to assess in a patient with psoriasis?
PASI scoring.
PASI scoring. So PASI scoring need to be calculated. So in a patient of erythroderma, what is usually the PASI scoring?
It includes 3 variables like erythema, induration, and desquamation. So body surface area is divided into 4 regions.
Now, what will be the maximum score I'm asking? So
72.
erythroderma, you'll have the maximum score, that is 72. So in a patient with erythroderma, even if you're not calculated, you know that when body surface area involvement is more than 90% and your patient is having erythema, infiltration, and scaling all over the body, most likely their PASI will be 72. That is the maximum score. Did you perform Auspitz sign? So which lesion would you choose to do a Auspitz sign? Is Auspitz sign generally positive in a case of psoriasis? I mean, erythroderma, erythrodermic psoriasis?
Usually it is negative. Ma'am, it is usually negative in erythrodermic psoriasis.
So if you have done Auspitz sign, which plaque do you choose?
Plaque
Or which lesion you choose?
with thick scaling and which has the recent onset.
So you choose a very well-defined plaque. Instead of diffuse erythematous lesion, you have to choose for a very well-defined plaque and demonstrate an Auspitz sign. That is why in erythroderma, because you are having diffuse infiltration, your Auspitz signs may be negative. What are the other types of psoriasis where Auspitz signs can be negative?
Pustular psoriasis, ma'am. Gutted psoriasis.
What are the components of Auspitz sign?
Yes, ma'am. First, we have to when we take on grattage, first scale, since the scales are loose, they are usually peeled off. And next on further grattage, we see a glistening membrane. That is because of the suprapapillary thinning of the epidermis, that is stratum malpighi. On further grattage, we see pinpoint bleeding points. That is because of dilated tortuous capillaries of the papillary dermis.
Okay. Now, what are the ways in which psoriasis can present in erythroderma? Chronic, this patient 20 years, he's been having psoriasis and now he's come to you in acute erythroderma. So what are the possible triggers which has triggered off this patient to develop an acute erythroderma? What are the general triggers? And in this patient, what was the specific trigger?
Emotional stress and history of usage of systemic steroids, sudden withdrawal of usage of systemic steroids, history of usage of topical applications, excessive topical applications like coal tar, diethanol, and also usage of other systemic medications like methotrexate, cyclosporin, and phototherapy.
Do they worsen?
Concurrent.
Are they triggers? What are the drugs that trigger psoriasis? Common drugs.
Antimalarials like HCQs, anti-tubercular drugs like isoniazid, and anti-epileptics like carbamazepine, phenytoin, and phenobarbital, and also allopurinol. And NSAIDs.
And most common is beta blockers. Yes, NSAIDs and beta blockers. Because many patients, they'll be hypertensive. Psoriasis is a disorder associated with metabolic syndrome. So patients can have coexisting hypertension or coronary artery disease, where people would have started them on beta blockers. So beta blocker is also an important trigger. So that is also something you need to ask in the history. So what are the possible drugs? And sudden withdrawal of both topical and systemic steroids. Both can precipitate a pustular flare or a unstable psoriasis where a patient goes into erythroderma. So you need to ask for all these triggers. Any other important trigger that you missed?
Infections, ma'am.
Very good. Infection, especially sore throat. We know that streptococcus sore throat infection is associated with gut-wide psoriasis. The same infection can also flare up a case of psoriasis. And especially in erythroderma with infection, you have something known as a superantigen mechanism, where the toxins released by your streptococcus and staphylococcus can worsen your erythroderma. So infectious trigger is very, very important. So infection, drug, stress are important triggers that you should always ask in a case of erythroderma. Okay. What are all the possible causes of erythroderma? So when you're taking a history, you've told so many negative histories. So let us classify the various possible causes of erythroderma.
A group of eczematous conditions like atopic dermatitis, seborrheic dermatitis, airborne contact dermatitis, and phytophotodermatitis. And papillosquamous diseases like psoriasis and pityriasis rubra pilaris, lichen planus, it is a rare cause, even though it is a rare cause. And immunobullous conditions like bullous pemphigus foliaceus, bullous pemphigoid, and infectious conditions like dermatophytosis, crusted scabies, and connective tissue diseases like cutaneous, acute or subacute cutaneous LD, dermatomyositis, and also other conditions like sarcoidosis, mastocytosis, graft versus host disease, and also drugs.
Malignancies.
Drug-induced erythroderma, drugs like antiepileptics like phenobarbital, carbamazepine, phenytoin, and due to malignancies like cutaneous T-cell lymphoma and other T-cell and B-cell lymphomas and leukemias.
Mostly B-cell lymphoma are present as nodules. T-cell lymphomas are the ones that will present with erythroderma. Now you told the major group of disorders. You have one side eczematous, you have papillosquamous, you have connective tissue disease, you have infections, you have drugs, and you have malignancies. Can you tell the possible clues which will give you in history, in examination, which will be possible pointers towards the group of disorders, which will help you diagnose the condition? Diagnostic clues.
In case of atopic dermatitis, usually the presentation starts on the flexures and involves there will be intense pruritus and history of atopy. In case of
Which other erythroderma is associated with intense pruritus?
cutaneous T-cell lymphomas, drug-induced erythroderma.
So these are when the patient complains of severe itching, we have to think either we are dealing with your eczematous group of disorders, or with a drug-induced, or other thing is Sézary, or even an erythrodermic CTCL, where the pruritus is quite intense. Whereas we know that in papillosquamous disorders or connective tissue disease or even immunobullous disorders, we generally do not come across pruritus as a major complaint. Okay, good. Then
in case of drug-induced, usually that is a rapid and sudden onset and history of some drug intake. There will be morbilliform or scalatiform rash seen will be generalized all over the body, including the face is involved, and facial edema is more prominent.
So facial edema is a very important sign to tell that probably a patient has a drug-induced erythroderma, especially the DRESS, the drug hypersensitivity syndrome. Facial edema is quite characteristic.
Associated with organomegaly.
So eczematous, you told, you started off with itching and flexural dermatosis. Then what all will tell? You told 3 disorders mainly in your eczematous. You told atopic, you told seborrheic, and you told contact dermatitis. So try to differentiate 3 conditions.
In case of pityriasis rubra pilaris,
No, first we'll finish eczematous and then we'll move on to the papillosquamous. So in eczematous, you tell atopic. When will you think atopic dermatitis? When will you think seborrheic dermatitis? When will you think of contact dermatitis? See, these are all only diagnostic clues. These are not foolproof, but at least we should be able to identify the clues in history and in examination.
seborrheic dermatitis usually greasy.
Yes, you have greasy scales. The type of scales are going to be different. You're going to have greasy scales. And what is the distribution of seborrheic dermatitis?
Scalp and flexural regions, perioral region, and upper chest.
In the front area of chest, in the V area of chest, and the upper back. So the seborrheic regions, you'll have predominantly the lesions with the greasy scales. When are you going to think of adult onset atopic dermatitis?
When the lesions are predominant over the extensors and there is a history of
Extensors and senile dermatitis. In adults, it is flexural dermatitis. Oozy lesions, flexural lesions with intense itching. And you can have other stigma of atopic dermatitis. of atopic dermatitis, and especially head and neck involvement is also a feature of adult onset atopic dermatitis. When will you suspect contact dermatitis or airborne contact dermatitis?
History of any contact history with the drug or any allergen.
Screen share.
Any support you can ask Mr. Rohit in case of any technical support. Support you can ask Mr. Rohit.
Hello, ma'am. Is there any problem to share your screen? Okay.
Hello. Sorry for the inconvenience. Are we audible?
Yes, ma'am.
Okay, ma'am. Yeah. Sorry for the inconvenience. Ma'am, are we audible?
Yeah, you are audible.
So we continue with the discussion now.
It's okay if your screen is not shared. I think we can continue with the discussion.
Okay.
So we are dealing with type of eczematous dermatosis, which can present as erythroderma. So far, we have covered atopic, seborrheic. And now we are discussing contact dermatitis. So you should ask for history of known allergen, contact with known allergen, and airborne contact dermatitis will have the typical pattern. Next, we move on to the next group of disorder, which you told, papillosquamous. So main two disorders, psoriasis and pityriasis rubra pilaris. So like in our case. So how are you going to differentiate a psoriasis from pityriasis rubra pilaris? And one more disorder, good that you brought in, that is Rieter's disease. So how are you going to differentiate these three papillosquamous lesions?
In pityriasis rubra pilaris, predominantly we see islands of sparing, that is napis flare, usually on the inframammary area, axillary areas. And we see follicular attenuation, that is follicular horny plugs are seen on the elbows and knees predominantly.
Also on the dorsa of the fingers. So that is known as the nutmeg grater appearance. When you try to feel for the lesions that are present on the dorsa of the fingers, those follicle-based papillary lesions will have a very rough texture. So that is known as the nutmeg grater appearance. Yes, so that is a important pointer. Presence of islands of sparring and presence of this nutmeg grater appearance on the dorsa of the fingers. And then any other thing?
There will be a
What is the
presence
color of erythema in a case of PRP and in a color of erythema in a case of psoriasis?
orange hue in the case of PRP, ma'am. In
Okay.
psoriasis,
What about palmoplantar keratoderma?
there will be presence of palmoplantar keratoderma with orange hue, ma'am.
So will psoriasis have palmoplantar keratoderma? You told your patient did have scaling in the palms and soles. So psoriasis will also have palmoplantar keratoderma. So what is the difference in the palmoplantar keratoderma of psoriasis from PRP?
Waxy keratoderma is seen, ma'am. In case of psoriasis rubra-pilaris. Fissuring and fissuring of the palms is also seen.
The voice is breaking. Is there a problem with the net connection?
Are we audible now, ma'am?
I am audible now.
So, yeah. In pityriasis rubra-pilaris, we see waxy keratoderma, ma'am. And also we see fissuring of the palms and soles, so that we can differentiate it from psoriasis.
Okay. What type of keratoderma do you see in reactive arthritis?
Keratoderma blennergica, ma'am.
Keratoderma blennergicum. So what are the types of scale that you see in reactive arthritis?
Limpet-like scales, ma'am.
Limpet-like scales you'll be seeing. Okay. So these are all the differentiating points from a psoriasis, from a PRP, from a reactive arthritis. What are the other lesions which can have a morphological presentation like a psoriasiform lesion that can present with erythroderma, other disorders?
Syphilis,
Very
pityriasis.
good. So when are you going to suspect syphilis?
Any sexual in syphilis, there will
Yes.
not be any
The
history
patient is a high-risk behavior. Yes. Then
there will not be any history of pruritus, ma'am, in syphilis. And
palms and soles involvement. You know that secondary syphilis will have typical lesions in the palms and soles. So in a high-risk behavior patient, you should always consider the possibility of secondary syphilis, especially when secondary syphilis is on the rise. So you know that SCLE can also present with psoriasiform lesions. So when are we going to suspect SCLE in patients with this kind of psoriasiform plaques?
when there is a history of any malar rash and photosensitivity.
Very good. So photosensitivity, when the lesions have photosensitivity, we are going to think of SCLE. So that finishes our psoriasiform group of disorders. Next, you told immunobullous disorders. So immunobullous disorders, three disorders that commonly present as erythroderma. One is pemphigus foliaceus, paraneoplastic pemphigus, and third one that you told was bullous pemphigoids. How are you going to differentiate the three conditions?
Pemphigus foliaceus usually present with the moist erosions with crusting and cornflake-like scales over the seborrheic regions, ma'am.
So how do we differentiate it from seborrheic dermatitis? There it is predominantly greasy scales. Here it is crusting that is present. Vesicles, history of vesicles and crusting in the seborrheic regions. Yes. Then
We can do biopsy to differentiate.
clinically first we'll finish, then we'll go for biopsies.
Bullous
Paraneoplastic pemphigus.
In paraneoplastic pemphigus, there is predominant involvement of oral mucosa with hemorrhagic crusting.
So when you have intractable stomatitis, when you have persistent oral lesions along with these vesicobullous lesions and crusting, you're going to think of paraneoplastic pemphigus. Bullous pemphigoid?
In bullous pemphigoid, there is a preceding history of pruritus and urticarial plaques, ma'am. Over the plaques, there will be a tense bulla and then leading to erosions.
Okay. So that finishes our vesicobullous group of disorders. Now going to connective tissue disease. Already SLE, we have discussed SCLE. More than SLE, it's SCLE that will present with erythroderma because of the psoriasiform lesions. Another thing is dermatomyositis. So when are you going to suspect dermatomyositis?
Presence of rash around the upper eyelids and over the heliotropic rash.
and Gaucher's patterns over the dorsum of the fingers, along with proximal muscle weakness, where the patient complains of unable to comb his hair and button his shirt. V-neck sign, a shawl sign.
Yeah. Good. So presence of these signs is going to give us a pointer towards the possibility of dermatomyositis. Now, most important is infections, especially with dermatophytosis on the being a menace. And we do see a lot of patients who come with dermatophytosis presenting as erythroderma. So when are you going to suspect dermatophytosis? When are you going to suspect crusted scabies?
Involvement, nail involvement is seen, ma'am. On the case of crusted, and in the case of crusted scabies, there will be a nail involvement with subangual hyperkeratosis and also hyperkeratotic palms and soles.
Good. And the kind of patient. Which are the group of patients that are predisposed to develop crusted scabies?
Drivers, immunosuppressed patients.
Immunosuppressed and
Patients who are
patients with neurological problems who are not able to scratch. Primarily, crusted scabies was reported in whom? It was reported in patients with leprosy. That's why it is known as Norwegian scabies, because it was predominant. It was first described from Norway among patients with leprosy, because they do not have the sensation of itching, they don't scratch. And so the mites just continue to be present in their body, and they have millions of mites, and they present with these kind of crusted scaly plaques. Okay, so the setting in which the patient is present, so that gives you a clue as to possible, or homeless people. So those kind of people are the ones with poor hygiene and all are the ones who are predisposed to develop this crusted scabies. Dermatophytosis.
We see annular plaques all over the body. Involvement of the scaling is a predominant. Intense pruritus.
You can have nail changes, you can have onychomycosis. So the important point here is, in any case of erythroderma, when you're not able to put them into classical morphology, always get a KOH done, especially with an increase in, whenever you find an annular lesion, always do a KOH to rule out a dermatophytosis. Now that leaves us the last group of disorder, that is malignancy. So when are you going to suspect malignant erythroderma, which could be paraneoplastic or it could be CTCL. So when are you going to suspect that?
there will be an intense debilitating pruritus, ma'am.
Pruritus is a very good pointer towards CTCL. Most important, you told that in your history of weight loss, loss of appetite. When your patient is having those constitutional symptoms, you have to strongly think of the possibility of a paraneoplastic or a CTCL. Any other pointer that will tell you that your patient is having CTCL?
Associated lymphadenopathy,
Very good, lymphadenopathy.
Alopecia and symptom of abdominal folds, which is known as Lecce sign.
Yes. Hepatosplenomegaly. Then cutaneous signs, fissuring in the palms and soles. Excessive fissuring and oozing of the palms and soles in a patient with long-standing erythroderma where you cannot fit into the classical morphology. You should always consider the possibility of an erythrodermic CTCL. Okay. And paraneoplastic, when you're not able to find the classical morphology, patients having erythroderma with constitutional symptoms of loss of weight and loss of appetite, based on the age group of the patient, we have to screen them for the possible malignancy. Now, we have differentiated the various types of erythroderma based on the history and examination. Can dermoscopy give you a clue to identify the various types of erythroderma? Now, all of us keep using dermoscope, right? So when we do not know the diagnosis, can dermoscopy give us a clue?
Yes, ma'am.
So what are the pointers? It's basically the vascular pattern. So when you see dotted vessels, that is classically seen in psoriasis. When you find reticular blood vessels, then that is seen in PRP. When you see spermatozoa like serpiginous vessels, that is seen in CTCL. When you see just linear vessels, that is seen in drug-induced erythroderma. So dermoscopy also can give you a clue to the possibility of the possible diagnosis of erythroderma, right? So now, till now, I've summarized what all we saw. We saw in a history of erythroderma what all we are supposed to take. History and examination. Examination should always talk about the body surface area involvement. And then you should also, when the history, you should always talk about the other causes of erythroderma and the complications of erythroderma. And then we saw the various diagnostic clues in history and examination to differentiate the various group of disorders and also in dermoscopy. Now, what are the investigations you would like to do to confirm a diagnosis?
For normal baseline investigations will be done, ma'am.
No, for
that
us
is-
to confirm diagnosis. We are dermatologists. So once we do dermoscopy, that's not giving us a clue. Next one is?
We do a biopsy, ma'am.
Very good. We'll do a biopsy. Now you tell me the various histopathological clues which will point towards the possibility of a diagnosis.
In psoriasis,
We see hyperkeratosis with the focal parakeratosis, and there is a hypogranulosis is seen. There is accumulation of polymorphonuclear cells in the stratum corneum, which is called Monroe's microabscess, which is a prominent feature for psoriasis. And there is accumulation of polymorphonuclear cells in the stratum spinosum, that is called Kagos pustules. And elongation, we see club-shaped elongation of the rete riches. Regular acanthosis is seen. Perivascular infiltrate is seen in the upper dermis. Suprapapillary thinning of the stratum malfigi is seen.
So these are pointers towards psoriasis.
in PRT, there will be an alternating pattern of orthokeratosis and parakeratosis, which resembles checkerboard pattern. And if the lesions are follicular, we can see follicular shouldering of parakeratosis around the follicle and follicular plugging.
So that's an indicator of PRP. So when will you think of eczematous dermatosis?
In eczematous dermatosis, spongiosis with exocytosis is predominant, along with acanthosis, and sometimes eosinophilia is seen in the dermis, which points towards atopic dermatitis, and lymphohistiocytic infiltrate along with the papillary dermal edema.
You told about drug-induced erythroderma also. So that is also going to have spongiosis. So any other feature in a drug-induced erythroderma which will give you a possibility that it's possibly drug-induced apart from eosinophils and spongiosis?
In drug-induced, there will be a basal cell macular degeneration and apoptotic keratinocytes in all the layers of
Very good. So apoptotic keratinocytes and basal macular degeneration pointed towards possibility of drug-induced erythroderma. So when are you going to suspect CTCL?
If there is epidermotropism seen, along with atypical cerebriform T lymphocytes in the dermis.
What is epidermotrophism?
Epidermotrophism is migration of lymphocytes into the basal layer of epidermis, along with without any spongiosis.
Yes, very good. That is what is going to differentiate it from a spongiosis. In spongiosis also, you're going to have edema and lymphocytes. So you call it as lymphocytic exocytosis. So how do you differentiate a lymphocytic exocytosis from an epidermotrophism? Is whenever you have spongiosis along with the lymphocytes, you know it is lymphocytic exocytosis. But when you have only lymphocytes that are atypical lymphocytes in the absence of spongiosis, then you have to think of the possibility of epidermotrophism. Good. Sir, would you like to ask them, sir?
Okay, regarding the condition in the patient, some of the areas you can see there are some types of pustular lesions also. You have missed any of those? Some areas you could see lesions which are more like infected or pustular lesions in the photographs. Go back to the photographs, please.
The
Next
lesion
one.
on the buttock, they were like pustules that were exfoliating.
These lesions. There are no pustules or all those things.
Well, actually, we could not see pustules. That is scaling, silvery white scaling over the
Lesion.
buttock region, sir.
Okay, then, okay, when you have gone into the management of the case, so you, can you recollect all what you can?
Yes, sir. So initially general measures were given, that is we have to hospitalize the patient and then the vital monitoring should be done. Most important thing is the temperature regulation. So ambient humidified temperature should be maintained approximately 30 to 32 degrees Celsius. And then fluid electrolyte balance should be maintained. So since there is a lot of scaling for the patient, most of the protein is lost. So we have to supplement with the good protein diet. This is for general measures, sir. In case of specific management, we started the patient on systemic steroid, that is dexamethasone, sir. And then we have given symptomatic treatment for pruritus. We have given antihistamines and we applied bland emollients like liquid paraffin is given. And in case for prophylactic secondary bacterial infection, to avoid the secondary bacterial infection, we have started the patient on antibiotic, and also there was lymphopenia, and so we have to start on antibiotic.
And along with the steroids, would you like to do anything else to control this erythrodermic process?
We could start. We actually planned for starting methotrexate for the patient, sir, on the next after tapering the steroids.
What does it say?
You can cyclosporin and acetretin can be given, sir. But since this is an acute condition, we wanted to start the patient on methotrexate or on cyclosporin.
Okay. Yes, madam. Madam, you'd like to continue?
Okay, sir. Okay. Coming to your treatment, why did you want to give your patient dexamethasone? Is that a first line of management for psoriasis?
This is not the first line of management for psoriasis, but since this is an acute condition of erythroderma, to decrease the inflammation and pruritus, we had to start on steroid, ma'am. And also the patient has a history of
Was
usage
that the
of...
reason that you started your patient? Was that the reason you started your patient on steroid? What triggered of psoriasis exacerbation in this patient? What triggered erythroderma?
There was a sudden withdrawal of steroid.
So he was taking 30 mg of prednisolone, which here there was an abrupt withdrawal, and that is what has precipitated this acute exacerbation. Apparently, there seems to be some pustules also, pustular flare also. So you have to put back the patient on steroids so that we gradually taper the steroids. Abruptly stop steroids. That is why this patient has been started on steroids for gradual tapering. The same thing about you have given your patient clobetasol foam on the skin. So that also has to be a gradual tapering, because when you're going to use clobetasol, a very high potent steroid, which you're using extensively on the body, that can also not be abruptly stopped. So how do you generally taper the steroids?
In case of IV, if we are giving the systemic IV, then after 3 to 5 days of symptomatic improvement, we decrease the dose by 25%. After 4 to 7 days, then we decrease it by 50% of the initial dose. Later on, from 7 to 9 days, we taper it completely, and then we move on to the oral systemic steroids. In case of if it is an oral, if we are giving more than 40 mg, then we decrease it by 10 we decrease it by 10 mg per kg. If it is more than 40 mg, we decrease it by 10 mg, ma'am. If it is below 40, then we decrease it we decrease by 5 mg. And if it is 25 mg, we decrease it by 2.5 mg. If it is 5 mg, we give 1 mg, we taper it by 1 mg per.
Okay, there are various steroid tapering regimens. The key point here is we have to gradually taper the steroids, never abruptly stop them. How do you taper a topical steroid? You're giving a patient clobetasol, right? It's just the principle. How do you taper it?
We give an alternate topical medication.
But
I
you
mean,
can
we gave
abruptly
him-
stop the steroid. So what
we
do you?
gave him alternate days, and then and
You can also reduce the potency of steroid. Now your patient is getting clobetasol, a high potent steroid. From a high potent, you can go to mid potent. From mid potent, you go to low potency, and then you can change the frequency and then introduce a steroid sparing agent, and gradually you can withdraw steroids from patients. Okay, fine. You told your patient was having lymphadenopathy, right? So what is the significance of lymphadenopathy in a patient with erythroderma?
so it is a dermatopathic lymphadenopathy, ma'am. There, because of the basal cell degeneration and there is a significant pigment incontinence, the macrophages collect the melanin from the dermis and take it to the lymph node, and hence it is also called as reactive lymphadenopathy, reaction lipomelanotic reticulosis.
Very good. It's known as
Lipomelanotic reticulosis. So this has to be differentiated from the lymphomas, ma'am. The
Lymphadenopathy due to
lymphomas.
yes.
in which there is an actual infiltration by the tumor cells, ma'am. In reactive lymphadenopathy, there will be an infiltration of Langerhans dendritic cells and histiocytes with melanin deposits, ma'am.
And there'll be paracortical hyperplasia. That is indicative of a reactive lymph nodes. Good. So what are all the complications that you anticipate in a patient with erythroderma? Acute erythroderma, you told, right? So basically, what are the complications of acute erythroderma?
Hypothermia and hypothermia.
Why do you
Anemia.
get hypothermia? Why do you get hyperthermia?
Hypothermia is because there is increased skin perfusion, so increased blood flow to the skin. As a result of this heat loss, there is a heat loss through convection and radiation method. So there is hypothermia. As a compensatory mechanism for this hypothermia, there is increased basal metabolic rate and shivering mechanism. So there is hyperthermia. And also,
when you apply so much of emollients, there's so much of occlusion, and that is also present to hyperthermia. Yes, then.
And there will be a release of interleukin-1 from the degenerated keratinocytes, which causes hypothermia.
Okay.
And hypoalbuminemia.
Why do you get hyperalbuminemia?
because of loss of protein through scales, there will be hypoalbuminemia, and the increased metabolism of the protein and also decreased secretion, release production of the protein also can lead to hypoalbuminemia.
And
Yes,
decreased
albumin is a acute negative phase reactant. So whenever you have any kind of inflammation, albumin goes down. Apart from that, here in psoriasis, you're going to lose the proteins in the scales. Of all the scaly dermatosis, where the protein loss is maximum through the scales? Psoriasis. Okay, they say it's to the tune of around 12 gram per meter square of scale that you lose per day with case of psoriasis. And it is to the tune of 4 to 5 in a case of drug-induced erythroderma or the other erythroderma. So there's so much of protein loss. So what is the implication of this? Knowing that psoriasis is going to have so much of protein loss? Therapeutic. So when you're supplementing them, the nutritional supplement, when you're giving them proteins, a psoriatic erythroderma, you have to supplement with more proteins when compared to other types of erythroderma, other causes of erythroderma. Okay. Then other complications.
high output cardiac failure.
Why cardiac failure? You call it as high output cardiac failure.
Due to increased skin perfusion and
Hypervolemia is seen because of increased blood volume, and as a result of it, there is
this peripheral vasodilation. So much of blood is going to return to the heart, resulting in high output cardiac failure. Then
acute renal failure can be seen.
Why acute renal failure?
Because of transepidermal water loss and fluid electrolyte imbalance, we see acute renal failure.
Because of dehydration, your patients may develop a renal failure. Yes, then
Anemia can be seen.
Very good. Why you will develop anemia in a case of psoriasis or a case of erythroderma? What are the causes for anemia?
Anemia, it could be due to loss of iron and folate in the scales or due to malabsorption due to dermatogenic enteropathy, which is
Very good. Dermatogenic enteropathy.
It could be due to chronic inflammation.
In psoriatic, in addition to dermatogenic enteropathy, can you have any other enteropathy?
Protein losing enteropathy.
Which enteropathy specifically in psoriasis? Psoriasis associated with the disease of the gut.
Celiac.
Very good. Celiac disease. So your patient can have, in addition, celiac enteropathy as well. So a dermatogenic enteropathy along with the celiac enteropathy, there can be more loss. Okay, good. Then
Pedal I see, ma'am.
pedal edema. Pedal edema, what are the causes of pedal edema?
Because of hypoproteinemia and hypoalbuminemia, and
Good.
also high output cardiac failure can also lead to increase.
Good, good. Then renal failure, that can also cause pedal edema. Okay. Other complications?
It could lead to secondary infections like pneumonia and sepsis. No?
So pneumonia and sepsis. Pneumonia, lung, you can have pneumonia, you can have ARDS, you can also have aspiration. If your patient is lying down, not moving around, they can develop aspiration pneumonia. So these are the lung involvement. Then you can have electrolyte fluid and electrolyte imbalances. What is the other problem? A patient is constantly lying down without moving around and patient suddenly develops a pain in the leg, swelling and pain in the leg. What will you think?
Decrease in vitamin D production and hypokalemia.
All that, and DVT, deep vein thrombosis. Your patient is not moving around and dehydration and all this can also predispose to deep vein thrombosis. So these are all the various complications your patients can develop. So much of facial erythroderma, face is fully scaly and all. What can happen in the face? What happened to the eyes? Any changes can happen as a complication?
Ectropion and epiforaman.
So epiforan, ectropion. See, these are all important things because during management, you have to pay attention to all these things. You have to give them emollients, eye drops. You have to
Lubricants.
plaster their eyes and all those things are very, very important. So these are all the variable complications. So when the erythroderma resolves, what are the complications that you can develop later? These are acute complications.
In loss of hair, shedding of body and scalp hair.
Good, alopecia then.
Nail changes.
Diffuse non-scarring alopecia, nail changes can be seen. Ma'am.
Okay. Any pigment changes?
Hypopigmentation is usually seen. Ma'am.
Because of scratching and all, they can have hypopigmentation. Sometimes they can even have hyperpigmentation. Then, do you develop multiple nevi or multiple seborrheic keratosis on the body? Multiple seborrheic, what are they known as?
Lesser relaxing.
They're known as Murray-William warts. They're basically not warts, multiple seborrheic keratosis that you develop after your patients heal, the skin heals with post-erythroderma. Okay, so now we have dealt with the complications. Okay, now proceeding with the management. So you told you want to give your patient fluid and electrolyte correction. You want to give your patient proteins and all that. So how much approximately are you going to give your patients? How much fluid? How much proteins?
So fluid electrolyte balance we calculated by Partland's formula, ma'am.
Very
That is
good.
4 ml per kg body weight into the body surface area. So on estimating that amount, we give half the amount in first 8 hours and remaining half in the next 16 hours. So we
See,
normally
that is for burns patient where there's so much of protein loss. Whereas for our patients with erythroderma with psoriasis, it's enough if we give them only half of the total dose. Okay, because already a patient is having high output cardiac failure. On top of that, if you're going to give a fluid overload, that is going to be detrimental to your patient. So you calculate the Parkland formula and you are supposed to give only 1/4 to half of that total dose, like the first 8 hours and then 16 hours. Clear? Okay. Proteins, how much do you want to give? Normally, how much protein do we require?
normal requirement is 1 to
1.2 gram per
kg body weight. Ma'am.
Yeah. Now they are going to lose so much of protein. So how much do you want to give?
We give human albumin, that is, we can supplement it with human albumin, 40
grams
grams.
diluted in 1 liter of normal saline. It is given
Like
at the
around 2 to 3 milligram per kg body weight. You're supposed to supplement them with protein. So that takes care of the nutritional correction. And then you wanted to give antibiotic because to prevent from infection, a patient had a fallen count or he had leukocytosis with lymphopenia. So you wanted to consider and give a prophylactic antibiotic. You wanted to give steroids because your patient was already on steroid. So you wanted to follow a tapering regimen. So now we go into the management of psoriasis. So sir was discussing that. So you told you wanted to give either methotrexate or cyclosporin or acitretin. So when your patient is having erythroderma, which would be an ideal drug to give among these three?
Cyclosporin.
Cyclosporin. Why?
Because it is a fast-acting drug compared to methotrexate and other
This
drugs.
is known as a crisis buster. So whenever you want an acute control of disease, you always give cyclosporin. What is the problem with methotrexate or acitretin? Or how long does methotrexate take to have its action?
It takes around 4 to 8 weeks, ma'am.
So for 4 to 8 weeks. In a chronic erythroderma, maybe you can give methotrexate, but it's an acute erythroderma where you don't want your patient to go into a decompensated state. So you have to have an acute control of disease. So in such cases, cyclosporin would be a better drug. So what are the things that you need to keep in mind before you start your patient on cyclosporin? Considering the complications that we spoke about erythroderma, right? You told erythroderma patients are going to have a lot of complications. So which are the complications if your patient is having that will you'll think twice before giving cyclosporin?
If the patient lands up in renal failure,
So renal failure is a possibility. So we have to rule that out. We have to hydrate your patient, and once only your renal parameters are stable, then you have to give cyclosporin. Other thing is
hyperkalemia,
and hypertension also. Okay, these are things. And then you have to start cyclosporin. What is the dose of cyclosporin?
3 to 5 mg per kg body weight, ma'am.
3 to 5 mg per kg body weight. Okay. Methotrexate at what dose you want to start?
We start at a dose of 7.5 mg per week, ma'am.
We can start with 5 mg test dose. So we'll start at 5 mg now. After 1 week, we'll go with the investigations. And then we'll increase the dose to 7.5 mg or 7.5 to 10 mg depending on the
Requirement of your patient. So now you started your patient on cyclosporin and then you're going to put your patient on methotrexate for long-term control. So what is this kind of therapy in psoriasis management known as?
Sequential.
So what are the other types that you know of?
Rotational therapy and
Very
combination.
good. Combinational therapy. So what is the difference between a rotational therapy, sequential therapy, and a combination therapy?
In rotational therapy, one therapeutic agent is rotated to another after a regular interval, ma'am. This is
So
to
why do we
reduce
do that?
Yeah. This is to reduce cumulative toxicity of a single drug, ma'am, and to decrease the resistance of that drug.
Very good. Okay. When do you go for sequential therapy?
In sequential therapy, it is given in 3 phases, ma'am. In the initial phase, we start with high potent drug, which have the high toxicity, which have the fast acting potential, ma'am. And in transition phase, we'll tap at the fast acting drug and then we add the low potency drug with less toxicity. And in maintenance phase, we stop the fast acting drug and then maintain with the low potency drug.
Combination therapy?
2 drugs are 2 therapeutic agents are combined
at low doses.
at low doses. ma'am.
So
This
to
is to
prevent the side effects of both the drug and typically, especially phototherapy or a combination of systemic and topical therapy. Okay, fine. What are all the biologics you would suggest for a patient with psoriasis?
TNF-alpha inhibitors like infliximab, etanercept, adalimumab, and golimumab, and monoclonal antibody against interleukin-17 like secukinumab, ixekizumab, brutalumab, bixekizumab.
What is the advantage of your what is the advantage of secukinumab, interleukin-17 blockers over your TNF-alpha blockers?
Interleukin-17 blockers are faster acting, ma'am, compared to the TNF-alpha inhibitors.
Apart from that, side effect profile. We go to a newer drug. One thing when we want a better efficacy, or other thing is we don't want a side effect. So what are the side effects of TNF-alpha inhibitors which we do not see with secukinumab? Okay, what are the common side effects of TNF-alpha blockers? What are we worried about in a country like India?
TB, reactivation of TB, ma'am. And also
TB reactivation. Is it a problem with the secukinumab? No. TB's reactivation is not a problem with secukinumab. What is the problem with secukinumab? Your patients are more prone for fungal infections there. Your interleukin-17, it's fungal infection. Another thing is paradoxical autoantibody production. Like you have paradoxical psoriasis, which is more common in which one?
infliximab.
TNF-alpha inhibitor. So that is the difference. Okay. So what is the prognosis of your patient?
Good prognosis. Good prognosis.
Since the underlying cause was identified, prognosis, and the patient is age group is around 40, and he has no comorbidities. Prognosis is good, ma'am.
So what is the comorbidity that you expect in psoriasis?
Like metabolic syndrome, like diabetes, hypertension, and hypertriglyceridemias, causing the cardiac diseases.
So it's always a good thing when you present a case of psoriasis. It's good to mention whether your patient has metabolic syndrome or not. You may not have the investigations with you. Lipid profile is important, but at least the waist-hip ratio, the BMI of your patient, and all that you can tell whether possibly metabolic syndrome or not. Other comorbidities?
Psychiatric illnesses like depression.
Very good. Your patient was on antidepressive therapy. Yes. Then
Obesity.
obesity, that is part of the metabolic syndrome. Then because of all metabolic syndrome, can you have any involvement of liver, which prevents you from giving methotrexate?
Yes, ma'am. Non-alcoholic fatty liver disease.
So that is also one complication, especially in patients who have obesity or metabolic syndrome. Then your patient is depressed, having psoriasis for 20 years. Is he predisposed to develop anything else? Substance abuse, alcoholism. You know, alcoholism is a trigger for psoriasis. Again, that's going to affect the liver, and again, problem with giving treatment. Okay, then psoriatic arthritis you have to screen for. And what are the nail changes in psoriasis? How common is it?
40% of the cases.
Nail. So we see nail matrix changes and nail bed changes in psoriasis. Nail matrix changes are pitting and crumbling, leukocytia or red lunula is seen. In nail bed changes, we see oil drop signs, almond patch, subungual hyperkeratosis is seen, onycholysis is seen.
Good. Sir?
Madam, there are some questions from the audience, I think.
Yes.
Doctor will read them out and then we can ask them also.
Yes.
Madam, we thank you once again for an extensive discussion. It was very, and it was really very.
They have prepared well and they've very well presented and
thank you.
answered.
Thank you.
Good, very good. One more tip for exam. You mentioned that your patient had taken methotrexate and cyclosporin and all. This patient is a teacher who knows what drug he has taken, and so he's telling. But otherwise, unless your patient utters the word methotrexate or cyclosporin in exam, it's better not to name the drugs, because then it means that you've seen the case record of your patient. Okay. So you can ask the patient whether they've taken weekly tablets or daily tablets or some applications. When did they apply? So if the patient tells the name of the drug, that is fine. If they don't tell, you always tell patient was taking some oral tablets. He took some weekly tablets, so probably methotrexate. That's a better way of putting it. But this is a teacher, so obviously he will know what drug he was taking. So that's okay that you told. And 20 years, everybody knows what drugs they're taking.
Yes, please, madam. One of the doctors, Dr. Archana Mathuri, wanted to ask which depressants the patient was on. Dr. Pranag, can you answer that?
So actually the patient did not mention on what antidepressant he used. That was a long back, but we probably think that can be some SSRI used. And in case of erythroderma, lithium can cause, it is one of the antipsychotic drugs that is most prompt cause for erythroderma.
So that's a very important question. What antidepressant? Because lithium is a trigger for psoriasis.
Thank you, madam. That was the only question which we got. And we go back to Dr. Kavita and Dr. Sujanya. Dr. Kavita?
It was an excellent academic feast, sir. We also have learned a lot, madam. Thank you very much,
Thank
Malti
you.
ma'am. And
Thank
I congratulate the PGs for their nice answering of the questions. And thank you very much, Subbarav sir.
Thank you.
And Saujanya is there?
Yes, thank you very much, sir. Thank you, madam, for accepting our invitation and helping out our PGs how to face the exams. And I thank our
I think yeah,
uh,
it's very, very refreshing to all of us.
and from our state, we have our dynamic president, Dr. Kavita, who takes this initiative every month. She wants to do more and more for our AP academics. And Dr. Sitaram sir is always there as our supporting backbone. And I thank them, and I thank the postgraduates for actively participating and our viewers of today. And I thank Erythroderma for their technical support. Thank you.
And thank you all once again for giving us this opportunity. And thank our department staff and students also for encouraging this program. Thank you all.
Thank you, sir. Thank you.
Thank you all. It was a good experience for me as well. And I deeply appreciate this initiative because this will be very, very beneficial for the postgraduates. And once again, the postgraduates did a good job. They have prepared very well and they were well prepared for any type of questions from any direction. So that was really awesome. So I thank all of you. Thank you for this opportunity.
Thank you, madam.
Thank you. Thank you all.